Welcome back to part 2 discussion about medically complex children on the autism spectrum. I'm Sarah.
I'm Christine, and you're watching Acorn Stories.
When we approach feeding and diet expansion, it's something we do slowly and we don't force anything. So the child is really the one that is experiencing up to where they're comfortable. And it's a slow moving process. The feeding tube allows for that to happen because they are getting what they need to be healthy and alive and grow. And at the same time, it makes the opportunity for it to be a diet expansion or a feeding program that is at their own pace.
Absolutely.
Yeah.
And we've seen parents consider going on to the feeding tube and saying yes or no. And then we've experienced the transition of patients coming off of the feeding tube, going to soft foods and liquids.
Yeah. Yeah, and every child is different, and you'll have kids that progress pretty quickly on and off. You'll have some that it takes a really long time. You have some that might not come off of the tube. And I know it's a really hard decision for parents. I think that it's pretty devastating to be told, well, they need to have this feeding tube placed. However, it really does then open up a world for exploration for that child in terms of eating and food and what they're comfortable with, while also maintaining bodily autonomy. So we're not forcing anything in anyone's mouth, right? But they are still being provided with the nutrients they need to grow.
Yeah.
Yeah.
But the tube feeding can be aversive to the
It
individual.
can. It can. And certainly at the beginning, I think like any large medical change, there is a change in how you can move. There's a change in maybe what clothes you can wear. You have to now maintain it, right? So there's daily routines that change. And so that can be aversive. Yeah. Um, I think, again, we can help with that in terms of the way that we present it, so that they're prepared for what that might look like as much as possible. And also allowing them to have some control. Maybe they assist with, opening the tube and as the nurse connects it, for example. Um,
I like that. It's very empowering.
yeah.
Kids like power.
Yeah.
Power is not just for adults. Kids like power. They like to be in control.
Yeah.
And they'll always tell you, they'll be like, okay, I'll be the teacher and you be the student. And they love that sort of control. So having them help the nurse.
Having them be involved, I
Yes.
think, because it's also their body, right? And we want to
Yeah.
teach them that, this is your body and you're making these choices to participate. Um, Giving them that opportunity, I think you're right, is really empowering.
Yeah, absolutely. And I think one of the hardest challenges is that with the G tube after they're fed, then usually comes, and this is just in my limited experience, a water flush where the child has to sit for close to an hour. And that can be really challenging for little ones who
Yes.
don't want to sit.
Yeah.
out.
So yeah, absolutely. Depending on the speed of the feed, and then the water afterward, it can be pretty long. Yeah. So having some activities that are only for when we're sitting, I think can be really helpful. Doing some pretend play, doing things that are really fun and reinforcing for that child during that time can be very helpful with those behaviors when they want to get up and they want to run around, right? So um, we can assist with that, and I think that we do a pretty good job in terms of coming up with creative ideas for, well, what can we do in this situation that will make this better for this child?
Yeah, and it comes down to pairing.
Mhm.
If
Yeah.
you have a neutral experience, and you're pairing it with something highly reinforcing, then the likelihood is that it's going to be reinforcing, that the reinforcing properties will override the neutral experience.
Yeah.
If something's aversive, you have to have something highly, highly, highly reinforcing. And even then, it might not always override the aversiveness
That's right.
of the experience.
That's right.
So, for example, having your child's favorite show
Mhm.
on television is one of the ways we get one of our medically fragile individuals to sit in the chair for the flush.
Yes.
Yeah. And it's like you get to watch Teen Titans
Yeah.
for an hour. And like that's part of their daily routine.
Mhm.
And the more you do things in a routine and allow them to be involved in it, I love that.
Yeah.
It seems like it would go better. Um, I asked this question at the meeting at our leadership meeting on Friday, and I always would still like to quiz the team. And I was like, "What did the empirical based interventions for feeding go?" And they were just like, "Did you see that?"
Yeah.
They're like, "What?" Like, "Yeah, let's name them out. Who's got one? Come on, people, who's got one?" And so we know that ABA does have some effective strategies and empirical based interventions for food expansion and food feeding. But then it comes right up against the line of medical, and you have to know where that line is to seek medical attention.
Yeah, and it kind
Yeah.
of goes back to what we were discussing earlier about, is this behavior or is this pain or is this something physical? Is this something different, right? So I think the best approach to feeding really is a multidisciplinary approach. Um, Behavior is certainly one of those components. And we do have some really good interventions that do work. Um, but we're not going to solve a problem with swallowing. We're not going to solve a problem with absorption of nutrients, right? So that's where we really need these partners in other fields to really usher that child to the most healthy outcome possible.
Yeah. And it's not always through behavioral interventions.
Yeah.
But let's name the behavioral interventions
Yes.
since we're here.
So the ones, and I'm sure there are more actually.
Yeah.
But the ones that we are very familiar with. First of all, escape extinction, which we do not do.
Yeah, that is I've seen escape extinction done. That is so aversive to anyone shoving something in someone's mouth. And I think the board really took a lot of great feedback and made changes for scent-based care. So
Yes.
escape
Yes.
extinction
Yes.
with food expansion should probably never be done.
Correct.
Yeah.
And just a quick reminder for those of us who haven't heard us talk about this before, escape extinction is where essentially the child is put into a position where they are not able to leave and food is put into their mouth until they eat it. As you can imagine, this can be pretty traumatic and can lead to some further problems down the line because if we are inflicting trauma, we're likely to cause further problems.
Yeah.
So
I never did that.
We don't do that.
Yeah.
We don't do that. Now
And,
that
you know, if you have good sense and discernment, you could look at that intervention and be like, "Yeah, I'm not doing that." I always tell all the clinicians and the trainees, like, put yourself in their shoes.
Mhm.
Would you like someone doing that to you?
Right.
If the answer is no, don't do it.
That's probably not the
It's
right thing to
probably
do.
not a
Yeah.
good choice. Yeah.
Yeah. Now there are programs that are inpatient that do use escape extinction, and I'm not here to judge anyone for what they're doing. I think that for the most part, people are trying to do the best they can to help their patients. I just know that at Nurture and Nature, we don't do that within a home setting, and I think it's pretty dangerous actually to do within a home setting.
Yeah, I've never
Yeah.
done it.
Yeah, I haven't either.
I don't think I ever would want to.
Yeah.
Yeah.
But it is an empirically based method. So there we've discussed escape extinction.
It is empirically based.
Yeah.
It
Yeah.
does have research behind it. It does work, right?
Yes.
And it basically looks like spoon to lip until you open your mouth and eat it, right?
Yeah, and then there's also a method where they insert a brush into the mouth and open the jaw to put the food inside too. So there it's pretty intrusive.
Yeah.
Yeah. Yeah.
It sounds pretty awful.
Yeah.
I think the feedback from the community on that intervention is probably pretty valid.
Yeah.
Because that reminds me of the book 1984. It's Orwellian.
Yeah.
I would not like that.
Well,
So I think the feedback's valid. Yeah.
it is valid, and
Yeah.
and I think that as a company we have decided it is not right for us and it is not something that we would do, but things that we do use for diet expansion.
Yeah.
So the PRT method is a favorite of ours.
Yeah.
Where we are using a hierarchy to present the food again and again, sort of a slow desensitization method with a strong reinforcer to move us forward. So maybe
Through all the senses too. Like,
Exactly.
the first is just looking
just
at
look
the
at
food.
it. Is it on the plate and are we okay with it being there, right?
Yeah.
That's step one. And if you really think about the things that you find most disgusting, which I think is really important for anyone doing feeding, we really have to consider, what would I do if they presented me with the most disgusting thing I can think of? And is it realistic for me to expect someone else to respond differently if they do truly feel disgusted by something, by a color, a
Oh,
smell,
yeah.
you know? So certainly when our children struggle with sensory input to begin with, it doesn't surprise me that there are things that would be icky.
Yeah.
Yeah.
Well, I told you about my big problem, how I drove my parents
Oh, yeah.
crazy when I was little.
She was a very strong-willed child.
It was like, if the food touches, I won't eat any of it.
Yeah.
I can't touch. We can't mix textures.
Yeah. 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 You can't leave the table until you eat that carrot.
Yeah.
And then at midnight, okay, go to bed.
Yeah, go to bed. That was liver. It's like, you're going to sit here until you eat this liver. I was like, yeah, I'll just sit here.
Mm.
My dad. It's time to get up and go to bed. I did not eat that liver.
Yes.
Yeah. And kids will do that. They will, if you give contingencies and you create power struggles,
You're gonna
they
get
might,
one.
yeah, you're going to get one and you might lose
Yeah.
because kids will do things like planned ignoring. Planned
Yeah.
ignoring can go off the rails because if a little child picks up an object and puts it to their eye and they're like, it's like, you can't ignore that.
Yeah.
And the child will know. So be
Yeah.
careful of the contingencies you set. That's
For
so-
sure.
But back to food expansion.
Yes,
So
so
PRT, we look
PRT.
at it, we touch it, we smell it, and very slowly.
Very slowly.
Yeah.
And the idea is that eventually you'll be able to take a bite and eat it without showing a sign of displeasure. So that is a sign that, hey, we are no longer very sensitive or very grossed out by this food, and we can move it into their regular diet. But it does move very slowly.
Yeah.
A similar method of a sequential presentation is done in speech and OT, but
Yeah.
that is done typically without a reinforcer. So similar idea.
And that's called SOS, right?
Yes, that's right.
Yeah. Very
Yeah.
similar.
Very similar.
But I think the PRT methodology is slower and more
It's slower,
systematic.
And it has that component of reinforcement,
Yes.
which leads me to another approach, which is our PREMAC principle.
Oh, yeah. Eat what's on your plate and then you get dessert.
Yes.
Right?
Yeah.
Yeah.
That's the idea.
Yeah. Or take a bite of chicken, then you can have your chips.
Yes.
Yeah.
Exactly.
And parents use that all the time.
All the time.
And like, you need to take 5 more bites. Yeah.
Yeah. Yeah. So also fairly similar. It just doesn't have that structured approach of, well, today we're just going to smell or we're going to look or we're going to touch. It's eat it and then you get this other thing that you like.
Yeah.
Yeah.
Absolutely.
And then mixing approach.
Simultaneously pairing, right?
Yes. So we take something that we know we like and a very small amount of something new, and we pair them together and then slowly expand on the size of the new item blended within this experience to pair something new with something that we already like.
Yeah.
Yeah.
Like quesadillas, right? So
Yeah.
if we want our child to eat broccoli, we start slowly putting broccoli in the quesadilla. We slowly start putting onions in the quesadilla.
Yeah. Little by little. And that also works with some families. Now, none of these approaches, I think, are right for everyone.
Yeah.
And
And they take time.
they take time.
And don't push.
exactly.
If you push too hard, you get a power struggle.
Yeah.
Yeah.
So another program that I really like, which is done preclinically, developed by Yev Averka up in Washington. Shout out to Yev, BCBA. She works on meaningful meal times.
Yay.
So it's essentially looking at not only consumption of foods, which a lot of us are focused on, but also what is the experience at the table? Are we connecting with one another? And sometimes just modeling of eating foods and just saying, oh, I like that is enough. If you can reduce the pressure on the child, and it will also reduce the pressure on the parent. And then over time, eating is less of an aversive experience for everyone.
Yeah.
Yeah.
And so to that, to try to make mealtime better and more reinforcing, bringing in crayons. Yeah. Bringing in small little toys for them to play with throughout.
Yeah.
Because
Yeah.
let's face it, a 6-year-old doesn't have the conversational skills to hold attention for an hour during mealtime.
And that's an excellent point because a lot of our kids on the spectrum struggle with social interaction and find it actually really taxing. And to come to a table, have to try new foods, and then also be expected to engage in this skill that's really difficult of socializing and having conversation can be really overwhelming.
It can be overwhelming for everyone, to
It
be
really
honest,
can.
right? If you're at a table. I remember one time I was at this wedding in Florida, and the people I was sitting next to at the wedding, it was like, oh boy. I was like, Kevin, switch seats with me. Why? I was like, this woman is strange. I was like, sat down for social conversation, was like, hi, I'm Christine. What's your name? How are you? How do you know the bride and groom? And she's like, she looked at me dead in the face. She's like, I'll tell you a riddle and you guess my name. I was like, Kevin, can we need to switch spots
That's a
immediately.
lot of work.
It's like, why? It's like, I don't know.
Isn't that
I don't know.
Rumpelstiltskin?
Yeah, I was like,
Rumpelstiltskin.
I was like, what is going on? I don't think I can sit here all night for a 6-course meal.
Yeah, so it can be overwhelming for everyone.
It can be, yeah. Especially when you're sitting next to a stranger.
Yeah, yeah.
It's like, oh,
That could be a lot of work.
yeah. It's like there's always that moment when you're going to a wedding and it's like, what table am I at? And it's
Yeah.
like there is a little pause of anxiety because I think
Yeah.
people are like, who am I sitting next to?
Yeah.
And what is
I went
is
to
the conversation gonna have to be?
Yeah, I went to a birthday party last night, for someone who was really important to my husband, who I hadn't met before. 5 tables, no place cards. You just had to sort of sit down and get to know people, and it was great, but there's certainly an anxiety, and if there's an anxiety for us, there's definitely an anxiety for a lot of our kids that we work with, in that social environment. But ideally, we should all come to a table, especially in our own home. We should feel safe. We should feel that there's a space for us and that we are accepted. And then also that we can nourish not only our relationships, but our bodies as well at the table. That's our hope. Yeah.
But psychological safety and
Yeah.
comfortability goes a long way in
It really
helping
does.
with feeding and mealtime in general. The simultaneous pairing can be such a great method. I think Shalina Brennan, of our executive clinical director, her son was like, Mama, why is the quesadilla green? She's like, oh, it's just new cheese. Just new cheese. you know but that's simultaneously pairing. Other things would be like sprinkles, right? Sprinkles on yogurt or sprinkles on oatmeal. Sprinkles can go a long way bringing the fun factor
Yeah.
to the table. Also, research has kind of alluded to cutting fruits into fun shapes and having like the 4th of July sparkler wands of watermelon.
Yeah.
And kids do like fun shapes in their food.
Yeah. And including them in the meal making process
Yes.
as well. It gives them an opportunity again to be exposed to the foods, but to hopefully pair it with a fun activity so that it becomes a less aversive, less scary experience.
Yeah, because sometimes things in bowls that you don't recognize, you're like, oh, I don't
know if I want that.
So identifying the food
Yeah.
and letting them see how it's made goes a long ways to unlocking that mystery for them.
Yeah.
Where they're maybe just
Maybe
aversively
that's
like, it's
just
a no.
scary.
And it's
Yeah.
like, oh, wait, I saw it. It had whipped cream and peanut butter or something,
Yeah.
Things I like. There was some things that I liked in that. So identifying the foods and showing them how it's made goes a long way.
Yeah.
How does sleep affect health and behavior in medically fragile autistic children and individuals?
So sleep is a big deal.
Yeah, it really is.
So if you have a child who there's a suspicion that they may experience seizures, one of the ways that we try to provoke a seizure under the circumstances in which it can be observed is a lack of sleep. So if we're not resting,
You're talking from a medical
medical model.
like in a hospital.
In a hospital, we're
studying
trying
it.
to figure out if you're having a seizure or not, and they get all of the equipment involved, but we need to provoke it to see if it's actually happening. Staying awake is one of the ways that is done so that it can be determined that, yes, they do have a seizure disorder, and yes, here's where it is and what we need to do to move forward safely. We don't do that at home for fun. No,
Never. Yeah.
But it does show you the power of sleep and what that can do. If you do have a seizure disorder, you're likely to provoke this experience, which in ordinary circumstances, we really don't want to happen. Further, if you are short on sleep, your immune system is less functional, more likely to get sick. Also, our preferences for junk foods increase.
I heard
Yes.
that when you are sleep deprived, you're more likely to go towards fatty, salty, sweet foods,
Yeah,
right? Yeah,
yeah,
I did hear
yeah,
that.
it's, I guess essentially a stress coping mechanism for some of us, but yes, sleep is so foundational to every part of our health system in our bodies, and also, our kids often struggle with sleep, and so we do see behavior changes that we can associate with, "Hey, they didn't sleep last night, and they are in no mood for any of this today." Right? So, again, that's why we need to be so flexible with what we're doing.
Absolutely.
Yeah.
Flexibility is key. When to
Mhm.
push in, when to pull out, when
Mhm.
it's not a good time to even approach. That's
Mhm.
the discernment that phenomenal clinicians learn over time is
Agreed.
like
Yeah.
the discernment of gauging where we are in space and time.
Mhm.
Where is this patient at in
Mhm.
terms of sleep
Mhm.
deprivation?
Absolutely. And what is the cost benefit of what I'm doing right now? Is this going to be a positive outcome? Are we going to learn today? Can we learn today? Or should we maybe back off a little bit today? Because if I try to force through something that's really difficult at a time when we're not functioning at our best, is it reasonable to think that that's going to be a positive outcome?
Yeah.
Right.
So if there is sleep deprivation, what the ABA therapist should really do is provide choices.
Choices,
Yeah.
maybe have a slower session. Maybe they just need to sleep today.
Yeah, maybe we
Maybe we
cancel.
cancel it
Yeah,
today. Yeah.
if there's no sleep, yeah.
Yeah. Yeah. So I think, that's a conversation to have again with the team, with the nursing team if they're there, or with the parent, um, to really just be on the same page.
How can ABA be adapted to handle medically fragile individuals?
I actually think this is really a cool thing because we're in the home.
Get your geek on,
That's
Sarah.
right. Um, as a soon to be family nurse practitioner in a clinic, I think that there is a limitation to what the provider can see and understand about that environment where the child lives. Um, I think pairing um, the provider with the people working in the home is really important because I want eyes and ears that are there to support that child. And I think that having a partnership between a provider and an ABA provider is really helpful. But to do that, we have to find a common language, and that can be kind of challenging. Our line graphs don't fit in well with other science, unfortunately. It's just not the way that it's measured. So we have to find a way to perhaps look at the notes that are on our patient summary and see if we can put our information into that type of format to share with the physician. Um, we can accompany our clients to their appointments if they'd like. It'll help with the behaviors while they're waiting. It can help them through the procedure that they're having that day. And it can also give us an opportunity to collaborate with the other professionals if the parent would so desire. So I think that those are some ways that we can assist, but we can also keep an eye on what we know as just people of what we need to do to be healthy, right? We need to move our bodies every day. We need to drink water. We need to try to get good sleep. We need to have good social interactions that are supportive. Um, we need to try to eat a healthy diet, right? So we can assist with all of those things in the home in a way that other providers can't. And I think that's a great opportunity for ABA to support health.
Yeah. Sometimes I support transitions, like if a parent has to go in to the hospital for a procedure, or if a child has to go into the hospital for a procedure for several days. I will use. I don't want to say it's a social story, but I will use visual priming
Yeah.
materials
Yeah.
in which I will make the child the superhero. And I'll say, Super Sarah. And I'll say, Super Sarah's going to go to the hospital and she's gonna meet nurses and doctors, and they're gonna have a bed, and, or
Yeah.
mom has to go to the hospital and you'll visit her here and there, and just really making a story for them to look at, like, about 10 days out from when the
Yeah.
hospital stay is. And I think that goes a really long way because the more they hear the priming visual, the more questions they have, and the more questions they ask prior to it happening, the more comfortable they feel. They
Absolutely.
get that information they need.
Yeah.
Like, are they gonna have ice cream in the hospital? Am I gonna eat hamburgers in the hospital? Will they have dino chicken in the hospital? Like,
Right.
it's,
Yeah.
because even then, sometimes in the hospital, when the dinner comes, you're like, "This is foreign. I don't eat Jello." Like, "This is ice chips."
Yeah. Yeah.
It's like, so the food itself in the hospital can also be foreign.
That's true. And
Yeah.
really, there's nothing scarier, I think, than the unknown, right? So it gives our imaginations a chance to run wild if we don't know what to expect in the coming days. So I think that's an excellent approach of seeing here's where we're going and these are people that we'll meet and this is what we can expect while we're there. At least takes a little bit of that anxiety away.
Yeah.
Yeah.
And just having the opportunity to have the questions be answered prior in that priming,
Mhm.
it goes such a long way towards psychological safety.
I agree.
Yeah. Um, how do you teach communication when a child has significant medical limitations?
So we really have to focus here on what the child can do. So we have some children that can make selections by looking in a field of two items, for example, to make choices. We have some children that are able to use what we would call an AAC device or an iPad, for example, that they can press or type to explain, what it is that they want or what they're thinking or feeling. Um, we have signing. Some children can sign to communicate. Now, sometimes the child may be really struggling to communicate in any of those ways, in which case it really relies on us to identify those signs of they look like they're uncomfortable. What what do I see here that could maybe change to improve the way that they are feeling? Um, and
And
that
we've done some great work.
yeah,
Like we've done big switches where it's like yes button and
yeah,
no button
yeah,
for them to communicate. We've also done ASL. Um but as soon as the communication comes, it has to really be taught in a very methodical way, whatever you
yeah.
go for. And a lot of people say multimodal communication.
Mhm.
So, I'm going to learn bathroom. I'm going to learn some signing. I'm
Mhm.
going to have my AAC device. I'm also going to be able to say yeah or
Mhm.
shake my head no. So, non vocal cues and communication.
Yeah, so all of that, I think it really does depend on the child and what they can do. And I really like focusing on what they can do well. And that will look different. So it's great, I think, to teach as many skills as we possibly can until we find what it is that works best for that child.
And sometimes one of the challenges is, in all honesty, is working with the insurance companies to get the equipment.
Yes.
The insurers are really can be very difficult to work with in terms of getting an AAC device, getting a Dynavox, which would be the eye gaze system.
Yeah.
These are big pieces of medical equipment and they require active training to utilize them,
Mhm.
skill training,
Mhm.
expertise. Um, I used a Dynavox to teach an individual and I put on the equipment and I tried to pick with the eye gaze and that was challenging for me to
Yeah.
be able to move the Dynavox system with my eyes.
And you have to be able to focus, I think, for
Yeah.
5 seconds.
Yes.
Yeah.
And it was it was very difficult to learn how to make that device speak for
Yeah.
me.
Yeah, and so sometimes, we're even just working on those prerequisite skills of can you hold gaze for 5 seconds on something,
Yeah.
right? Um, we've done adapted versions of that when we don't have the equipment to have, pictures that are displayed on a field that the child can see, um, to use that to make selections and to communicate, which isn't ideal. Ideally, we would have the system, but it does take a while. And that's really true of all medical equipment standards for some of our kids with CP, different types of wheelchairs, different adaptive equipment. It's really challenging for parents to get the things that they need. And I really wish there was a way that we could lessen that burden.
Absolutely. Because it just seems like parents have to go through hell to get like an adaptive
Just to get
wheelchair
the basic things
or like
they
a
need.
Hoyer lift to
Yeah.
take their child out of bed or their
Mhm.
teenage son out of bed, you know? It's like it
Yeah.
seems like they have to fight tooth and nail to get the
They really
adaptive
do.
equipment and
Yeah.
to be honest, it has to stop.
It really does.
It's like
Yeah.
yeah.
Yeah, because the consequences of not having those things, if you're in the same position, you're ending up with bed sores in your skin, which can become infected, and then you're septic. And now we have a much larger bill and a much more dangerous outcome than if they just had the equipment to start with. So I really think that some policy has to change so that, the decision is in the hands of the parent, less so than that of the funder.
Absolutely. 2 interesting medically fragile cases that I worked in my career. One was Rett's
Okay.
disorder,
Mhm.
and Rett's disorder is, a developmental disability, um, and that disorder doesn't necessarily have a long adult lifespan. It's known
Mhm.
for having a shorter lifespan, which can be very scary. It also deals with, um, shutting down of some communication systems. So at 10, my patient was speaking vocally
Mhm.
and then could not speak.
Yeah.
And then could not use her AAC device. And
Mhm.
so we actually went for big pictures on the floor where she would stomp on to communicate
Yeah,
because that's what she could do. Um,
absolutely.
and then another diagnosis that I worked on was mitochondrial disorder.
Mm.
And that medically fragile case really came with a lot of, you had to have a lot of discernment because it was like he has oxygen. If he goes blue, we
Mhm.
stop, he gets oxygen.
Mhm.
There was many, many, um, nurses on that team, and for me, it really came down to quality of life and
Mhm.
constantly examining the cost-benefit ratio,
Yeah.
because there was a perceived shorter lifespan associated
Mhm.
with these diagnoses. It was like, "Well, let's do things that make him happy and
Yeah,
engaging," because
yeah.
you only live once. And, when you're working with children that are highly impacted with their oxygen level,
Mhm.
you want them to have, again, positive reinforcing learning opportunities.
Yeah.
And then there shouldn't be any distress.
Yeah,
Yeah.
and I think
It's
one
like,
of my favorite things about working with nature and nature is that every program is tailored to that child's
oh, yeah.
needs. And it's nothing, we're not targeting things that won't ultimately improve their life. And if you take a look at the big picture and say, well, we could spend the next hour working on matching this red triangle to that red triangle, but it's
Yeah.
going to make no difference in this child's life, and they're going to be miserable doing it. It's not worth doing, right? So I think it's really important that all APA providers take a look at what are we targeting and what is it doing for the client, and is it something that is worthy for them, and is it something that falls into the values of that family? Yeah,
Yeah. And cost benefit.
yeah,
Yeah.
yeah,
Because quality of life at a certain point, from a nursing perspective, I know from a behavior analytic perspective, I've looked at quality of life maybe less than a dozen times on cases where I'm like, we really need to have super reinforcing positive experiences on a daily basis for this little one.
absolutely, yeah,
But how does nursing take into affect
yeah.
quality of life versus cost benefit?
Yeah, so, working with older clients or older patients, for example, if they're coming in, to the clinic to have their annual, or if they're coming in, you know, um, for some sort of acute issue, I think that most family nurse practitioners and primary care providers are really looking at that all the time. There are a lot of interventions that maybe could be done or a lot of testing that could be done, but some of that is painful. And what is the ultimate benefit, right? If it's really, you know, intrusive, aversive, painful experience and it's going to result in what, if it's not a real great improvement in quality of life or a real great improvement in lifespan, if that's what we're focused on, um, is it worth doing? Right. So I think that, in the primary clinic sense, that's where it comes into play. Now, nursing on a acute floor, for example, in the hospital, that comes into play as well. I think in conversations that the nurse would have with the provider, the physician, whoever is overseeing that patient. Um, because we really should understand every medication we're giving, every intervention that we are performing, what is the benefit and what is the risk of not doing it, and what's the risk of doing it, because that's something that the families should really understand before decisions like that are made.
For, people in general and for kids that are getting treatment and adults, what safety considerations are most important in the home?
Oh, there's a lot.
Yeah. I would say healthy habits, right? Like good hygiene, wash your hands when you come inside, wash your hands after
Absolutely.
eating, clean surfaces,
Yeah.
sanitary trash procedures, regular home cleaning. For me, it's about hygiene.
Yeah, that is really important.
Yeah.
Certainly, we want to avoid any opportunity for infection, or unnecessary illness, like a foodborne illness. If we're eating things at home, uh, we certainly also want to look at where that child's space is. Are they mostly on the floor? Are they in their chair? Are they in their bed? How is that being maintained? You know, from a nursing perspective, is our skin clean? Is it dry? Right? Are we rotating and not staying on the same spot on our back if we're laying down, for example? I think if we're mobile and we're up and moving about, our electrical outlets covered? Are there dangerous items in the area that our client could put in their mouth and choke on? Right. So it's really a lot of situational awareness as well. Um, I think absolutely healthy habits. We could all use that.
Yeah.
Really.
And then very
Yeah.
specific safety plans for each individual in
Hmm.
your care.
Yeah.
So, for instance, like we talked about, the child that had mitochondrial system, if they turned blue,
Hmm.
they brought the oxygen line immediately there.
Yeah.
Um, Other things, very specific safety plans. So, like febrile seizures have to do with seizures that occur when you have a very high fever.
Yeah.
So, that particular safety plan would look at having a ice cube cold bath dunk
Hmm.
immediately to get the fever down, right?
Yeah.
So,
So
very specialized, very specific safety plans
yeah.
for medically fragile individuals.
Absolutely. And also, a good tracking system for medication dosages, how much is given and when. Medication errors can be really awful. So, making sure that things are tracked appropriately and that everyone knows exactly what is supposed to be going on. I think communication is so important, from provider to the nursing team to the caregiver, everyone involved.
Yeah.
Yeah.
And then preparing for medical emergencies. We teach that in all our programs. And
Hmm.
I really love emergency preparedness. That is like my jam. I geek out on it. Like I have water and backpacks and apocalypse cookies packed away, and I really am about
What kind of
emergency.
cookie is an apocalypse cookie?
A nut or better. Yeah. And those last a long time. Just like spam, right? Doesn't
Yeah.
that last a long time? But, like, emergency preparedness and, like, it hasn't failed me because, I mean, you remember when COVID hit and they were, like, the KN95s? I was like, "I think I have about 150 of those." And Sarah called me and was like, "You need to give those away." I was like, No, I'm gonna use them for nurture nature because
And we needed them.
they were nurture nature's emergency preparedness, for, like, fires, and so we had KN95s
Mhm.
ready to go because of my obsession with
See?
emergency
It pays
preparedness.
off.
But these are skills we actively teach little
Yes.
kids is like what to do, if there's a fire, if mommy falls down, if,
Mhm.
the what if situations. And we teach
Mhm.
this both in role play and through, I'm Spider Man and, call the ambulance,
Eh.
So we'll teach it through actual play, interactive play. And we'll also teach it with visuals.
Mm.
But there should also be constant teaching
Yes.
of emergency preparedness.
Yeah. Yeah, it's important that we have things planned ahead.
Yeah.
Um, and I think the skill set you're talking about building is really a lifelong skill set that that client should have. Is this an emergency? Is this not an emergency? What should I do in case of this happening? Because the worst situation, is where someone does get injured and then there is no help provided.
Yeah.
Yeah.
My husband actually had to put his foot down because we're in Los Angeles and there was the horrific Palisades fire and the Pasadena fires that we lived through. And that was really horrific. And we tried to help as many people as possible. But I was like, Kevin, we need to get the thing that makes the pool water pump into a hose to spray the house. Or we should get the fire tarps, because I learned about the fire tarps up in the national forest where you have to cover your wood in these fire tarps. I'm like, "The fire doesn't penetrate these tarps?" Like, "No." I was like, "We should get tarps for the entire house." Kevin was like, "No, we are not doing that, and you can't get that $1,000 pool pumping water hose system." It's like
Well,
but
fine.
but I was like, "But what ifs?" Sometimes I like to prepare for the what ifs, but I mean, not to get children to be paranoid, but if there's a fire, who do you call? If someone, those community safety helpers, what to do if
Yeah.
you lose track of mommy and Target,
Yeah.
like you should actively teach these skill sets
Yeah.
to children. And it should be a part of their ABA
I
program.
agree.
Yeah.
Yeah.
But when you're dealing with a patient that is medically fragile, emergency preparedness takes on a whole new level of
Absolutely.
being prepared.
Absolutely.
So what does that look like?
Yeah, so we talked about the medication list and having that ready to go. I think that's always really important. And having a little book would be really great with your medications, your diagnoses, your providers, your insurance information, all of the things that you might need should you have to suddenly make a fast trip to the hospital. Um, recognizing those signs and symptoms. So you mentioned the little boy turning blue. There's also little devices you can put on your finger that tell you your oxygen
Yeah.
saturation in your body. That can be really helpful. Takes 2 seconds. If that's a concern, I think that's a really helpful thing to keep around. And then what are we seeing? Is he having a seizure? What should we do when he's having a seizure? In the past, they used to say, put something in their mouth. And we know you don't do that anymore because you're more likely to choke them or to have some harm occur by putting something in a person's mouth when they're having a seizure. So typically the advice is roll them on their side and protect their head until it's over and then, get them to emergency services. Um, but
And then a bag ready
a
to go.
bag,
What should be in the
I
bag,
think what should
nursery?
be in the bag is some change of clothes, should be any medications, maybe some, backup medications to have available. Also, those toys we talked about, right? Having some activities, some things that will make them feel more comfortable should they be admitted into the hospital or should you have to wait in an emergency room for a certain period of time. Um, and then, of course, that book with the medications is really important to have as well. I think also a phone charger is a smart thing to have should you need to contact family or should, for whatever reason you're in the ER waiting, you need to contact someone. Um, yeah, so I think, and it would also depend on that specific child. If, we do have oxygen that we need to make sure we have with us. We do have, the feeding materials. Should they have a feeding tube, you need all of that medical equipment ready to go. Should you have to leave in a moment's notice.
And then apocalypse cookies.
And apocalypse
We
cookies.
should really consider the
This episode brought to you by Nutty Butter Apocalypse Cookies.
But having comfort foods, it's so important, right? Because it's like sometimes it's the simple thing. It's like, oh, a chocolate chip cookie. Okay.
Yeah.
It's like, and we talk about food being comforting for individuals. Next question. How can schools support medically fragile autistic students? And I think this is a really good question because sometimes they do a really crappy job doing it. And they're like,
Yeah.
we don't have a nurse at school. They can't come to school. It's like, well, that's illegal.
Yeah.
Like, this is where
Yeah.
maybe do better can apply a bit. I don't know.
I think that's probably true.
Yeah.
It could,
Because they're getting rid of school nurses,
yeah.
right? They're like the first to be cut.
I have a friend that's in school nursing here at LAUSD, and I think really enjoys her work. But I think it depends on what school you are in and what the resources are available in that school. It's sort of similar in a way, I think, to our insurance issues of, you know, there's not a lot of budget set aside for these schools. There's not a lot of support, but at the same time, they have to legally require, it's legally required that they provide it. So I think having some more specific guidelines for these schools and for the team would be great. I think schools could help by one, being very flexible and understanding this child has different needs, which means maybe they're not going to be there on time today. And that's not a big deal, right? But we do need to be ready for them because they deserve to come to school. They
Yeah.
deserve to have interactions with peers that are safe if possible. I know we have some clients that receive some school service at home, which is usually pretty brief. And I haven't heard a lot of great feedback about that system, but at least it's some sort of education being offered to our kids. Um, but I think what schools
The
could do.
the
Mhm.
the at-home video can be problematic because it's not you're just watching a video of a classroom, and is there benefit? Maybe. Maybe there is benefit,
Yeah.
but there is less benefit than being in the actual school environment, and I see
Mm.
sometimes, kids can't go to school because certain school districts won't provide the nurse.
Yeah.
That's when I think you need to get an advocate immediately involved
100%.
or an
Yeah.
educational attorney. Um,
Mhm.
because usually when parents lawyer up, guess what?
There's a nurse.
There's a nurse, there's a walker, there's an adaptive bike for your
Yeah.
individual, and but I think I've met several parents in Los Angeles where they're like, the school said they're too sick to go to school, so they just stay home. It's like, no,
Mhm.
get them to school,
And
make
that's
them
why.
provide a nurse.
Yeah,
Yeah.
these parents need advocates like you because you make these things happen. I've seen it. It's really cool.
Thanks, Sarah.